So as I said, you'll hear a bit more from me through the day, but first of all it's for me to welcome Warren and Mike and to talk through some of the stuff that's going on in Manchester. So first of all we'll hear from Warren Heppolette about some of the stuff that's going on with Devolution. We'll have it's 15 minutes from him and then 10-minute Q&A, and then we'll hear from Mike Burrows about how some of the other stuff is going on, and again we'll have a 10-minute Q&A and get you into lunch. So without further ado, over to Warren. Thank you.
Thank you. This works, doesn't it? Morning, everybody. I hope everybody can hear me. I'm going to cover a bit which I think is kind of scenery, really, for change in relation to health and care in Greater Manchester. There's a fair bit of what I'll cover that is pretty wide lens, quite a big picture. I will, as we kind of go through the next kind of 10-15 minutes or so, cover a bit around why devolution occurred and why we pursued it in Greater Manchester, how we're reacting now to the opportunity, what that might mean in terms of a radical transformation of the landscape of commissioning and provision. But specifically, I think, kind of teeing up what might be some of the content for later in the day about the opportunities that might create for greater degrees of independence, choice, control on the part of patients, what assisted living can do in the context of Greater Manchester, and how the turn that we think we're going to make in the way that we organise health and care and the way that we affect the relationship between the public and their public services might start to speak to this agenda in particular in terms of our ability and capacity to adopt this kind of work at scale across Greater Manchester. I think a bit about what's in what's in our heads when we talk about devolution and the opportunities that we're presented with now, because where this starts, I think, is a recognition, firstly, that health and social care was quite a recent and quite an unusual addition to a national devolution agenda. And there's a particular reason for that, because I'm sure that you're familiar with a lot of the talk around devolution over the last 10 or 15 years, and even in Greater Manchester, particularly over the last 5 or 6 years, where we've gone through 2 or 3 iterations of devolution deals. The concentration really has been on the big kind of solid hard edge stuff around infrastructure, business investment, skills development, all of that kind of stuff. But Greater Manchester's got a very particular problem that meant that actually that could only be part of our solution in a devolution conversation, because whilst we've over the last 10, 15, 20 years have made significant progress in terms of securing and building on our economic potential, there's been a real lag in terms of our ability to connect all of our population to the benefits of that economic growth. So throughout that period, regardless of how well we did in terms of inward investment and economic growth, we had resistant, large-scale, long-term unemployment. So that recognition that actually we needed to do something specific about connecting the population to the benefits of economic growth became real. And the more we looked into it, the more we saw that actually 60 or 70% of that long-term unemployed group in Greater Manchester had long-standing mental health conditions. About 25% of them have long-standing musculoskeletal conditions. So for those of us on the health and care end of this discussion, we could see a real responsibility around our ability to be able to improve the health of the population in order that they can find and keep good work and participate and achieve their potential. Because the bigger level picture is that Manchester can't achieve its economic potential unless we address that challenge. So health and social care moved right into the middle quite quickly of even the kind of the political leadership end of what we want to achieve through devolution. And an improvement in the health of the population becomes a make or break competence for Greater Manchester as a successful place to live. From the moment we started that conversation with that kind of analysis, we moved unusually quickly, it felt and was, to a significant agreement with NHS England in that document, the Memorandum of Understanding that we signed in February this year. The basic premise behind that agreement was that we made a case around fragmentation. We made a case around the fact that we couldn't maximise the benefits of the health outcomes that we were pursuing because we were operating in a system with significantly fragmented commissioning, and significantly fragmented regulation. And our ability to manage change and manage change quickly and manage change at scale was hampered because everybody was facing in different directions all of the time. So that's the kind of the core argument that says actually part of the opportunity and the leverage that devolution has to bring is the ability to address some of the fragmentation. That needs to occur locally, so we need to see a significant shift in levels of collaboration. That exists in the neighbourhood level in terms of collaboration of frontline teams, in terms of collaboration between the population and their public services. It needs to exist at the organisational level in each part of Greater Manchester in terms of collaboration across sectors. And it needs to occur between Greater Manchester and national bodies, so we see greater degrees of collaboration as a consequence there. The heart of the deal, really, is the fact that NHS England says we can address some of that fragmentation for you by handing over our commissioning responsibilities and the resource that goes with it. So that's one problem off the table. What we need in return from you, Greater Manchester, is a picture of a path to sustainability for the health and social care system. So all of the stuff that you hear around the £30 billion financial problem across health and care nationally, we have our share of that, and we understand what drives that. We understand that there are demographic factors, there are elements of inbuilt projected demand due to the rising burden of disease across the population. And we've got a current system that doesn't feel like it can meet that demand on its current configuration. So we project our share of that is something in the region of £2 billion over the course of the next 4 to 5 years. So we have to, between now and December and go live of devolution, which is April next year, show in a single plan what that path to sustainability looks like. Our kind of moral compass around this is recognising that the big question we need to answer around how do you secure sustainability for health and social care system is one that says how do you maximise the health potential of Greater Manchester's population? Because if we set that as the question, suddenly the places we might go to look for answers look very different. And I'll say a bit more about that, but it goes immediately beyond the formal health and social care system. I'll show you this just so you can offer me some sympathy. So I'm in the heart of trying to construct a strategic plan that says what does sustainability look like and who contributes and how do they contribute. And all of this has to come together across 37 organisations, working together in localities, working together as sectors within health and social care, and working together across Greater Manchester to produce a significant single plan that says over the next 4 to 5 years, we think we can start to secure significant benefits to the health of the population. We think that we can start to stabilise that pattern of demand which runs currently out of control, and we think we can describe how we would organise ourselves in order to be able to do that. Part of what starts to come out as the answer, I think, has a very sort of simple starting point. That if you're looking at that scale of complexity and thinking, how on earth do you kind of brigade 37 organisations around a single plan, the outputs of which will have quite difficult consequences for them as individual organisations. There are a couple of things that need to sit in our mind that when we start to get towards solutions. The first of those is that we're explicit about the priority that people and place need to take over organisational self-interest. And for those of you that work very close to the health and social care sector, you'll understand why that's a significant shift in cultural terms, because we have a system that is characterised by a sense of competitiveness amongst itself that we need to shift quite quickly into a system that's characterised by a sense of collaboration and mutuality between itself. So that kind of priority of people and place is really significant as a declaration of a cultural shift. The other big set of judgments I think we make is that if we think of that approaching demand and the £2 billion problem going forward, what that tells us is we've got a significant leadership choice that we either meet that demand in exactly the same ways as we currently meet demand, which means probably that we need to build some more hospitals, or we change the nature of that demand, which means doing things very, very differently. Now, I think the leadership choice here is pointing at doing the latter. So I think we need a two-part strategy. There are still things that we need to do to meet today's demand in more efficient and effective ways. But there are enormous things that suddenly become possible when we start to address the question of how do we change the nature of demand in the system. Because the stuff that we get into then is recognising all of the international evidence from MARMA and the World Health Organisation and the others that give the NHS a real moment of humility, where we need to recognise that we are potentially between 15 and 25% of the solution to the problem of improving the health of our population, the formal health and care sector. The stuff that makes the bigger difference is when we genuinely get into the way that people live their lives, the social determinants, their ability to find and keep good work, the income levels that they develop when they're in work, the relationships they have, the connectedness they have, our ability to overcome isolation, loneliness and vulnerability, and our ability to wrap a wider public service into those responses to the early signs of vulnerability. And make our population active participants in that, do what Wanless described 12 years ago and generate that demand for good health. So we suddenly see that actually our health and social care system doesn't look anything like it does at the moment, because we start to see contributions coming from all parts of the system. And that's partly because different bits of the system outside of the formal health and social care setting are alert to the early signs of vulnerability that we know are going to start generating health disbenefit if we don't do anything about them. So they're in. It could be visible to a housing officer. It could be visible to an employment support officer. It could be visible to a school teacher. And there are triggers and there are triggers and signs and signals of vulnerability that means that actually, if we were serious about early intervention and prevention, they would trigger interventions that would be relevant to the health sector, but they might not be delivered by the health sector. To give one example of where I think our thinking's gone furthest on that, we've got a Greater Manchester Fire and Rescue Service for about the last 10 years have done these, what they described previously as home fire risk assessments. And it was about smoke alarms, it was about the risk of fire in the dwelling, and it's hugely successful, has driven down dwelling fires no end. But what it means is their organisation to be able to deliver that means that they find and enter the homes of the 60,000 most vulnerable people in Greater Manchester every year. And obviously that 60,000 changes because they've responded to it. What we've done with the fire service is rebadge that and say, actually, if we can co-design that with you and rebadge it as a safe and well check, it's an enormous public health intervention that we could make. And instead of do the stuff on risk of dwelling fire because it's relevant to you and it's relevant to us, but let's also think about what we can do to get your eyes on some early signs of vulnerability, whether it's about slips and trips hazards for the frail elderly, whether it's to do with substance misuse or mental health problems. Let's not try and fix a £2 billion problem in a £6 billion health and social care system when we have a £22 billion public service system that can also help. So that level of integration is radically wider and different to the one that we've described before. We do have all of the stuff that everybody would expect about the integration of health and social care, and we're seeing enormous shifts in terms of the state of pooling of budgets across health and social care, and our indication is that when we get into devolution April next year, we'll have pooled resource across health and social care of something like 2.8 billion across Greater Manchester, so that's nationally significant. We also think that beyond that new set of relationships that'll take place in localities and in neighbourhoods, there is something serious that we need to do about horizontal integration across hospital trusts, and we're starting to pick at some of that, and we've got some track record recently through kind of specialty services connected together whether it's stroke or hyperacute or major trauma, connected together across numbers of hospitals. And we need to think much more widely about how that can support a more mutual arrangement between hospitals and extend the kind of joint working they would do. And where that gets us, so we've got about 3 weeks left to do a kind of first iteration of this strategic plan. And then we need to blow the doors open on a set of conversations with our population, with our frontline staff, that start to test the hypotheses of what we're saying. Because from April, we need to be really serious about us stepping into a new way of working together that is much more characterised by collaboration, sees Greater Manchester connect itself together around a single plan for health improvement, that has an opportunity to be a point in the century where actually we think we've got 2 centuries of poor health in Greater Manchester and we've got an opportunity to shift it. So what we need to start thinking about is actually, with all of that, if we can generate a degree of consensus around an ideology for reform in Greater Manchester, what's the improvement architecture and how do we fit the system together? Because there are a number of elements that I think come out of things like the Dallas programme that give us real prompts to say, actually there is something about interoperability of the way that we manage information across our system. There's something about the way that we construct contracts and payment that don't incentivise the kind of shifts that we're looking to do. There is something about the way that we offer public services that don't offer the opportunity of more control and co-design from populations. And we need to think seriously about how we amend all of those things. So we're on the brink of something quite significant, I think, and it's coalescing the whole of the public service that needs to open out into a much broader conversation involving 2.8 million people. And we need to think about how we equip ourselves to do that. And needs to have much more reliable single front doors around how we drive large-scale change across the whole of Greater Manchester, because the degree of improvement that we need to pursue is enormous and not able to be delivered by organisations working on their own. And I think that's it for me.
So we'll open up for Q&A. I think there's a roving mic somewhere. Here we go. So anybody got an immediate question? I'll try and... Here we go at the front. I think we've got one over there. That's all right. That's all right. If you pass it here, I think. Here we go. There we go. There you go.
Thank you very much for that. That's a very ambitious program that you have, and it certainly seems to be the way forward. A question I have for you is that one of the biggest challenges facing healthcare in the UK and Manchester, will be one of the leaders in that, is in terms of problem of multimorbidity, people who have multiple chronic conditions. And I see you've got the person as the driver, but still at the side you have the specialist services there with their various different paradigms. I wondered how you think you're going to draw together for the person who's got heart failure, chronic lung disease and diabetes, who sees multiple specialists trying to coordinate that and didn't minimize the treatment burden, the self-care demands that the system place on them as we move to make people the activated patient and make them the expert patient. Then that involves a lot of work, and how we're going to increase the individual's capacity to deal with that work.
I think the first thing is that the way I think this will play out in terms of the almost the sort of construction of the construction of the service is that one of the central problems that's visible in that approaching demand problem, but not visible in terms of the way that we work with individuals at the moment, is that we've got this enormous gap between the prevalence of disease in the population that we know about and our ability to kind of proactively manage it. So part of the shift that we have to make is to something that is much more systematic about anticipatory proactive care, which means a very different model of neighbourhood provision that is much more broadly based, much more multidisciplinary, much less defined by individual specialty professional,ism, takes as its cue a much more kind of holistic, whole person, whole family view, because part of the drivers that will sit behind the problems that family are going to overcome won't need to be met by a medical response. So actually, it's more than a multidisciplinary team in the context of multimorbid conditions. It's a multidisciplinary team in the context of a kind of successful potential of an individual and their family. So I think what we're starting to see in Greater Manchester is the construction and scope and approach of that kind of neighbourhood level operation of populations of kind of 30 to 50,000 that is much more able to take that full kind of whole person view. It's starting to be characterised, and this will be familiar to lots of people in the audience, through more of those kind of generic care coordinator type roles that are starting to kind of broker an intelligent blend of different sorts of public services, social, medical, non-medical, in order to be able to respond to the full range of problems. And what that means, I think, is almost a different kind of conversation with the public, isn't it? That actually spends a bit more time at the outset and doesn't just load traditional, fixed medical responses, but starts to think differently about the blend of problems and challenges that we're looking to solve. So I think that the construction of those kind of more broadly based, integrated, whether we call them, accountable care organisations or whether we call them health benefit trusts, whatever they are much more broadly based in character than fixing just health and social care together. But there's a different approach that is more, I guess, a care plan that's more co-produced by an individual patient, and that'll be the way that we start to get the full picture in that care plan.
Okay. Other questions? One just behind. There we go. Thank you.
Yes. Can you hear me?
Yep.
My name is Mike Chandler. I've got a question on how you would position the concept of service excellence in this wonderful work that you are leading the way forward. What I'm trying to say is that the way in which patients and service users interact with the system is a function of the quality of the service. And in the business world, there is a service excellence program which has gone round the world, which has transformed those businesses that have taken it on board, because it's a culture change. I wondered where you would think that would sit in what you're trying to do.
I think there's part of our... I mentioned the kind of the word humility before, and that's partly around the humility of health and care services in recognising the extent to which they can't solve their own problems. But I think there's a degree of humility that we probably need to take on board quite quickly and at quite significant scale, that recognises the extent to which we don't, never mind service excellence, we don't even apply evidence-based good practice in all settings across all areas of care. So I think a big part of this collaboration, consolidation, sort of coalescence of the set of objectives we pursue and the way that we organise ourselves as teams and organisations across health and social care as a consequence of devolution will give us much more leverage in terms of, firstly, adopting best practice and being a more receptive platform for concepts like service excellence and the methodologies that we might use around things like improvement science and the adoption of improvement science at scale. I don't know whether Mike will probably touch on some of that as well, I think, in his presentation.
Okay. Other questions? One in the middle, I think. Yeah, thank you.
I'm the chairman for Crawley CCG and also a member of the West Sussex Health and Wellbeing Board. Even just that first session, so much to think about, to take back to our Health and Wellbeing Board. So thank you for that. For years, health and care systems have rehearsed the argument about ageing population and the need to change how we go about our business. And more often than not, when we engage the public, whilst they can understand the need to change, if the need to change leads to reshaping acute services and there'll be fewer of or more focus, then the public tend to wobble. So I'm interested in how you either have or how you plan to engage the public so as they can be heavily involved in those conversations and make sure that you don't face the same wobble that the rest of us have in the past.
Yeah, I think the first thing to say is that this, although a lot of the focus around devolution was sort of exploded on February the 27th when the agreement was signed and that it was clear that we had a programme to operate with NHS England. It wasn't the start of the conversation with the public, because actually, the reform of health and care services is a kind of continuous journey, isn't it? And one that we'd started to take proactively, because if we weren't already talking with our public and across organisations about some of the changes that you're kind of touching on, we probably wouldn't have had enough credibility for NHS England to sign the agreement with us. So what sits behind this is, I think, somewhere between 4 and 8 years worth of work where some of those kind of first steps on probably more specific services have started to be taken. So people get more and more comfortable with the concept of the centralisation of the most specialised services. And we were on that path with the responses to heart attack, to stroke, to major trauma. What we did last year through the consultation on Healthier Together was, I think, extend that slightly to sort of see where you could generate the opportunity of hospitals working together across larger catchments as part of single services. So it feels more like a continuum, really, where you start to make the case where in Greater Manchester nobody balks at the idea of their cancer treatment coming from the Christie, because excellence is expected and people will travel across Greater Manchester for the Christie, and that's become more of a familiar idea around some of the kind of the once-in-a-lifetime hospital treatments. And the thing that we've opened up over the course of the last 2 years in particular is the idea that actually we can help hospitals meet some of their own financial challenges and some of their kind of service sustainability challenges and some of the development of their staff if they work together on larger catchments. So it feels like it feels more like a journey than suddenly kind of coming out of the woodwork with something that's very kind of hard-edged and different. So I think we keep having to kind of rely on actually all of our organisations in all of our localities have been on this path of describing both some of the consolidation of acute services, but also some of the possibilities and developments of locally based integrated care that starts to provide more of their care closer to home as part of the same journey that we're on. And the difference that devolution makes is one to do with pace, because we think we need to do it faster than we have been doing, and one to do with scale, that means that actually we reach for a standard across the whole of Greater Manchester rather than having pockets of excellence in parts of Greater Manchester.
Okay. I think we've actually just reached our 10 minutes, so we'll try and keep us on time. I think as well Warren's got to leave us quite briskly
12.
to get to to get to his next meeting. So I'd suggest we move on. So over to you, Mike, if that's okay.
Good morning, everybody. I'm Mike Burrows. I'm the Managing Director of the Academic Health Science Centre in Greater Manchester. The purpose that Academic Health Science Networks were given 2 years ago by NHS England was very broad, actually. We were given 4 licence conditions, which, I'm honest about it, gave us a licence to do just about whatever we wanted. I have to say, in some cases, some academic health science networks have done that. But there's a broad theme around service improvement and working to improve population outcomes. We cover the footprint of Greater Manchester as well as a couple of little bits added on as well. There are 15 academic health science networks across the country. We're directly funded by NHS England. We are member organisations. All NHS organisations are required to be a member of an academic health science network. So a number of crossover points really in terms of what Warren's already talked about. A year into our existence, the devolution announcement was made for Greater Manchester, and that's a great opportunity for us, and I'll talk about why I believe that is in a short moment. As Greater Manchester Academic Health Science Network, we have a value proposition about establishing a platform in which partners can come together. Maybe that sounds a bit glib, but I'll just go on to elaborate what I actually mean by that in a moment. In terms of our aims, we're seeking to deliver that mandate for NHS England in terms of improving health outcomes. Critically as well, though, there's a really important aspect of health and wealth in terms of the work that we undertake. So yes, creating transformation of NHS services, but working with partners, particularly in academia and industry, to support that transformation. And all of that underpinned by the informatics work that we're undertaking as well. So in terms of the DALS programme, the academic health science networks generically fit really well in terms of how we can take the work that's emerging there and ensure that we get it into NHS practice. The NHS Constitution states that NHS organisations, or the NHS as an institution, should be operating at the cutting edge of science. And very often it doesn't feel like that, does it? From discovery to full implementation in healthcare services, there's a timeline typically of 15 years. I wish I could source that statistic. I don't know whether it's a UK or an international statistic, but that's clearly too long. And in terms of the imperatives that Greater Manchester and Devolution has, and indeed the rest of the NHS has, we cannot afford that 15-year time lag. So it's one of the key roles that academic health science networks have, is to accelerate the adoption of innovation into NHS organisations. I had the very good fortune last month to go to a medtech conference in the US, and I saw some of the research that the NIH in the US is funding in terms of some of the new molecular diagnostics, and it was absolutely jaw-dropping in terms of some of the technical aspects of research and how you can see it's going to touch on just about every aspect of patient care pathways that operate within our hospitals currently. And it really did ignite a passion in me in terms of thinking we just simply cannot wait for that 15-year time lag to occur to see that innovation getting into our clinical practice. And we've clearly got the imperative in terms of the financials as well to make sure that that happens. So it's really important for us. So Devolution came along about 1 year into our existence, about the time I joined the Academic Health Science Network. And for us, it's been a fantastic catalyst, really, in a number of ways. Firstly, as Warren and his team establish the single governance arrangements in Greater Manchester, it truly does give us the opportunity to make sure that innovation is adopted at scale across the footprint of Greater Manchester. That's a population of 2.8 million people. We work with a number of really great organisations who've got some really neat innovation, and I'm sure some people in the audience will recognise this point, and they work with an individual NHS organisation and get that technology evaluated and prove the benefits in that organisation. And then they need to go to the next organisation and knock on that door and go through their procurement processes and convince another set of clinicians and care providers of the benefits of the innovation that they have. And then another, and then another, and then another. And it becomes an expensive process, a time-consuming process, and one which really isn't in the interest of the broader NHS as a collective group of organisations in terms of that aspiration of getting the best innovation into practice. So having a single governance arrangement in Greater Manchester is an opportunity for us to make sure that we can produce a pipeline of that innovation that goes through a single decision-making gateway. CCGs and trusts may have to cede some of their sovereignty in that process, but I don't think the Greater Manchester partners will be pursuing devolution unless they didn't realise that there are benefits in operating at scale and in certain cases surrendering aspects of their sovereignty for single decision-making processes in the interests of the greater good. So that works really well for us. It works really well for us as well because Warren and his colleagues have got an enormous financial challenge that they've got to deliver, 2 billion over the next 5 years. I'm probably counting at the moment. And simply doing more of the same, as Warren suggested, is not going to deliver that. So there's an essential requirement to make sure that good disruptive innovation is being brought into solving the challenge of the Greater Manchester Strategic Plan, and clearly moving from a reactive healthcare system that Warren described to one which is proactive, that can empower and enable patients, and hopefully also get into preventative care as well to avoid ill health being acquired. There's no difference there from the rest of the country, if I'm honest about it. The final benefit I think it brings to us, and it's particularly relevant for the Dallas programme, this, is that it does enable us to look at a completely different set of economics. It's not a case of putting an intervention in one part of the healthcare system to deliver benefits in another part of the healthcare system. We can look now to a broader perspective on the public sector. Certain interventions provide benefits in the healthcare sector, in social care, and I hope as well through discussions I know Warren and his team are having, into the much broader aspects of the public sector purse, including benefits, for example. If we could begin to negotiate that type of deal with the Treasury, then wow, that's a whole different ballgame, isn't it? And some of the work that we're doing now can certainly demonstrate those broader benefits. And I think it will make the investment case for some of the new technologies that we want to invest in far easier. So it's exciting. Just to finish on a little bit of the work we do, we have 4 programmes of work now, all interconnected. I won't go through them in detail and bore you with that, but the informatics platform is particularly important. We want to ensure that data is shared effectively to make sure that individual citizens, obviously with the appropriate information governance wrapped around that, the right information follows them so that their clinicians and care providers are taking the most informed decisions. It also creates tremendous benefits in terms of research opportunities and the ability to manage the resources that we have. A key role with industry and wealth, I've talked about getting innovation into clinical practice, clinical and care practice, but there's also an added dimension there to make sure that the local organisations we work with, the SMEs, that we can actually boost and support those organisations to navigate the complex procurement mechanisms we have in the NHS and get them to grow. Creates jobs, creates wealth, it's good for health, it's good for the economy. It's a very positive reinforcing circle, isn't it? Health and implementation, we do I guess some of the conventional service improvement stuff. We also carry responsibility for patient safety. And that fits quite well actually with some of the innovation work we're doing, and it's also underpinned by the informatics. We do some information analytics work as well, which is termed utilisation management. So the Dallas programme for us, I think, is a great opportunity to bring those components together. And I'd suggest in terms of the challenge that Greater Manchester has and the description you've heard from Warren in terms of what the local NHS organisations are trying to achieve, Dallas sits extremely well. It sits well indeed with the 5-year forward view that was produced by NHS England, because the economics of it are an absolute no-brainer. We have to move away from the reactive system that we've got, which is expensive and addresses the symptoms, to get to a much earlier diagnosis of the broader problems we've got, to make sure that we can maintain people in healthy lifestyles and where possible undertake the preventative measures that were spelt out so well in Marmot et al. Just want to respond to a question that was asked about quality improvement. That is a key feature of the work that we do. We fund capacity and capability building across member organisations around service and quality improvement. I think the secondary care sector are making tremendous progress in that area. I think there's a challenge at the moment. This is a science which is beginning to be picked up within primary care. I sense there's probably a 5 to 10 year time lag in terms of where secondary care is now with service excellence and continuous improvement and quality improvement compared to primary care. Having said that, the best examples I've seen of primary care are right up there in terms of international best practice in terms of service and quality improvement. So that's a little bit about Greater Manchester AHSN. The components I've talked about there, I know people have come from other parts of the country, you'll find in just about all of the other academic health science networks. So I'm not talking anything unique here that we're doing in Greater Manchester. We do operate very effectively as a group of 15, and the features I've talked about are common to those 15 academic health science networks across the country. Thank you.
It is midday as well. So. Okay, any questions? Looking out. No, okay, so just one from me then, Mike. I mean, you mentioned there about obviously the group of 15 across England, I guess. I mean, so how do you then interface into other, like, sort of, say, Scotland, Wales, Northern Ireland? How does that work?
Well, it's interesting. The academic health science networks only cover England currently. There are similar mechanisms in the other parts of the United Kingdom, but I think it's unique that NHS England has put the funding into the set of arrangements that we've got. That there are a number of aspects of our functions that exist in Scotland. I liaise with colleagues in Edinburgh who do aspects of the informatics work that we're doing, for example, an engagement with their digital health sector. So it's very similar. It's got different titles and I suspect different funding streams. I think in terms of academic health science networks, we occupy a unique space which has never been occupied by an element of the NHS before in terms of that direct work with industry, particularly with SMEs, to make sure that we can break down the barriers that organisations so often face in working with the NHS. I have a procurement team now that part of a piece of work we've got called Innovation Nexus. That team is not there to do procurement, it's to work with providers to assist them through those procurement processes. And other resources as well in terms of support, ensuring that you get your pitch right in terms of what NHS organisations are looking for, creating the opportunity for new products to be evaluated in the NHS to generate the evidence base, working with NICE indeed as well to make sure that we can assist in steering some of those evaluations as well. And I'm not sure that the NHS has ever attempted to do that previously. So a bit of a brave experiment for NHS England in doing this, but I think we're already beginning to see some really great benefits. We're working with some great SMEs locally and getting their innovation into clinical practice. And you know, maybe that wouldn't have happened as rapidly if we'd not been about to provide that support.
Okay. Right. Any questions triggered from the audience? No? Okay. Yep. Well, we have one. There we go. Thank you.
Hello, Jonathan Butters from Moro Limited. One of the key issues that tends to inhibit the adoption of new goods and services into any market is end user buy-in and engagement from those who are going to benefit from systems. I'm involved in user-centered design of products and services, quite a lot of medical. And I worked up in Newcastle, and there's something which I'd like to ask if you've considered something that's been done by the Institute for Aging and Health in Newcastle, where they've got a network called Voice North. It's several thousand people of the older age group, particularly because they're interested in aging and health. But that group's available as signed up to be consulted, engaged at every stage of the development of new goods and services and the adoption and the catalyst for change, which is very useful. And I can see you've got a very complex environment in which you're operating. Lots of individual firms, organisations, right from individuals upwards. It's very difficult for each of those small groups or larger groups to create some sort of overarching consultation pattern that's consistent. Is there any move in Greater Manchester to form something like Voice North? So I suggest if you're not that familiar with it, it would be very valuable, because I really feel that the end users are often left out, or only lip service consultation at the end of processes. I know that as a professional, because I've seen lots of products fail in the market, lots of services fail because end users are not involved and engaged with. They're usually very willing because they've got insights to share. So I suggest, if you haven't considered it, you should do. If you have, great. What's the view from the panel on that, please?
I think it's really important that we get that pull from service users. It's far easier to get adoption of good innovation into practice if there's the pull rather than the push. And the document that was published a couple of weeks ago, the Accelerated Access Review, which was about getting innovation into practice, that majors as its number one theme the importance of engaging patients and members of the public in that whole cycle. I've just come from a meeting this morning where we've been debating this very point, and the innovation pipeline that we're designing, which will hopefully bolt into the Greater Manchester Strategic Planning arrangements, will have a full piece of work around patient and public engagement as part of the prioritisation setting, to make sure that it's not, people who sit in offices like me or even clinicians, but that we get the end service users properly engaged in identifying where that innovation should occur. A piece of work like SBRI as well, where we've done extensive work with service users to identify the challenges and put those back to industry in terms of what type of innovation needs to be created to address the challenges that we've got. But I'll have a chat with you afterwards, certainly, about the work you've done. Thanks.
Thank you.
Any other questions? No? Okay. Well, in that case, I suggest that we try and pull that together and have lunch. So we've heard about the great stuff that's going on in Manchester, and good to know that you want to learn from some of the things from Dallas. So I think we've all been wanting to learn from that as well. So we'll hear more about that this afternoon in terms of what's been going on in the various communities, you know, what's worked, maybe what could have been better, and maybe what we should be thinking about doing next and sharing across the country. So enjoy your lunch, and we'll see you back here. I think we're at 1 o'clock kick-off back in here. So if we could be back in promptly a few minutes before that, that'd be good. Thank you. Thank you, both.